Yeah. Hi. Hi. A very good evening, one and all. And I'm just checking out whether it's live streaming or not. Okay. Yeah. A very good evening. So this is our eighth live session. So in this live session, we'll be discussing a few multiple choice questions pertaining to endodontics, right? So I've chosen few topics and I'll be discussing on them. And if you have any questions, you can comment and I'll be discussing them simultaneously, right? So we'll straight away go into the topics, right? So coming to the first question, see endodontics. Before that, I would like to briefly tell you, like when you're referring, when you're going through endodontics, right? So I have already posted a weekly schedule and also the list of important topics, right, in YouTube. You can refer that for more information. And when you're referring endodontics, right, make sure that you have the standard textbook references, especially Grossman, Engel, as well as Cohen, right? So especially from Cohen, I mean we have a lot many questions. Where you can find explanations, elaborate explanations in Cohen, right? So make sure that you have this standard textbook references, right? And along with that, practice as many multiple choice questions as possible. And what I found is, like, they'll be asking you more of case based questions. There is a scope for asking you case based questions. They can post some radiographs, and then based on that they can ask you, they can formulate several questions. And also we have questions on various rotary instruments also, right? So various rotary systems like pro taper next, or hero shape, right? We can expect several questions from the cross sectional design of these instruments as well, right? If you observe the previous 2 or 3 year entrance exam papers, then you will have this understanding, right? So before that, so hope you have gone through the videos, like the weekly schedule and also the important topics list. And weekly schedule, make sure that you follow your own this thing. But see, I've already provided you the weekly schedule on day-to-day basis, right? You can refer that for a basic understanding and for a basic idea. And also I mentioned in that video that you need to practice as many multiple choice questions as possible, maybe 100 or 150 depending upon your capacity. And make sure that you refer. See, while you go do MCQs, make sure that you complete the referring answers. No matter whether you're right or wrong, you should make a habit of referring answers along with the explanatory part, and then standard textbook references, and then customized notes, and then come back to synopsis, right? So try to follow this cycle, right? So when you're practicing multiple choice questions, and that adds to your knowledge, and ultimately that increases your confidence as well, right? So we'll straight away go into the multiple choice question discussions, right? So I'll be reading multiple choice question, and then we'll be discussing a related topic pertaining to that multiple choice question. So coming to the first one, a 7-year-old boy arrives at dental office with a complaint that one is draining pus into his mouth, the anterior front tooth region, upper front tooth region, where the patient complains of draining of pus into his mouth from that tooth. The tooth had been traumatized earlier. The vitality tests reveal no response. What is the treatment of choice, right? So we face these kind of questions in endodontics, in periodontics as well, right? So I'll just read out the question again, and then we'll go into the options and then a discussion. A 7-year-old boy arrives at a dental office with a complaint that upper front tooth region 1 is draining pus into his mouth. The tooth had been traumatized earlier. The vitality tests reveal no response. And what is the treatment of choice? And the options given were extraction, apexogenesis, root canal treatment, periodontal surgery to remove sinus tract, Apexification, analgesics, and antibiotics in order to relieve symptoms. So we have several options here. It's a previous NBD question. So basically, in the question, we have certain clues or hints, we can say, right? So the age of the patient, if you observe, it's a 7 years, right? So 7 years means it's a clue in the sense, as they're mentioning that it's 1 in the question. So 7 years, it's the root apex closure is not still complete. So eruption of central incisor, as you all know, happens at around 6 to 7 years or 6 years, right? So it takes around 2 to 3 years for the apex to get closed in case of permanent dentition. So till that stage, till 9 years or 8 years, we call the tooth to be in a YPT stage, young permanent tooth, where there is wide canal, blunderbuss canal, and the apex is not closed, right? So from the question we can make out that the tooth which is in question is an young permanent tooth, and also they clearly mention the vitality status of that tooth. The vitality status as revealed by vitality test is no response. So as I've been discussing in e-classes side, so no response to vitality test indicates that the pulp is either necrotic, or there can be even differential diagnosis. I will not discuss, will not go into details there. So no response indicates necrotic pulp, right? A non-vital pulp. So they have mentioned the vitality status, and also they have mentioned the root apex condition, right? So these two parameters are important for us to answer this question, for that matter any question in the same genre, right? So root apex is open, it's not still closed, and the vitality pulp is non-vital. So in such cases, usually what we do is, our aim is to form a calcific barrier in the apex, so that at a later date root canal treatment can be done and obturation is possible. If the apex is open, obturation, we cannot get that apical tuck back, we cannot get that hermetic seal or fluid tight seal in the periapical area. So for that reason, what we do is, in such cases we try to get that root apex closure physically by means of calcified barrier formation, either through MTA or calcium hydroxide. Once the apex closure is obtained, then we go for a conventional root canal treatment. So this procedure which I have explained is nothing but apexification, whereas apexogenesis is something which is done in same, remember, whether it's apexification or apexogenesis, these treatment protocols are followed in case of young permanent tooth, the tooth with immature apex or wide canals, right? So in such cases, depending upon the vitality of tooth, we go for either apexification or apexogenesis. If the tooth is vital, then what we do is we try to go for pulpotomy, preserve the vitality of the radicular portion of the root, and then promote physiological formation of root apex, right? So this is called as apexogenesis, and apexogenesis is possible only when there is vitality, right? And when the tooth is non-vital, then we need to clean the canal, place calcium hydroxide or any high alkaline material, and promote physical barrier formation or calcified barrier formation, and this is called as apexification. Ultimately, either in apexification or apexogenesis, once the root apex closure is obtained, we go for conventional root canal treatment, right? Conventional root canal treatment followed by obturation and all, right? So this is about apexification. So to answer this question, a 7-year-old boy arrives at the office with a complaint of 1-1 draining pus. So it's a non-vital tooth and it's an young permanent tooth, and the treatment of choice would be apexification, right? Hope it's clear. And coming to the next question, which condition is characterized by pain that is spontaneous and has periods of cessation? So we have options: reversible pulpitis, irreversible pulpitis. So the question is, which condition is characterized by pain that is spontaneous and has periods of cessation? See, the reason why I chose this question is because we'll have scope to discuss regarding the clinical features, signs and symptoms of reversible as well as irreversible pulpitis, right? So usually, in case of a reversible pulpitis, if you compare the nature of pain, see, pain has to be described under several subcategories. Like for example, what should be the nature of pain? What should be the what is the nature of pain? What is the intensity of pain? What are the aggravating factors, relieving factors, and what are the various symptoms associated? What are the various signs? So we need to look pain in different dimensions, right? So when you compare reversible and irreversible pulpitis, before going into the differences, I would like to highlight upon main characteristic findings of pain, especially related to irreversible pulpitis. See, in case of irreversible pulpitis, we have this nocturnal pain, right? Because nocturnal pain, in the sense, or when you tilt the head or when you lie down, what happens is there is increased cephalic blood pressure, which gets translated to the pulpal pressure. Since pulp is an enclosed space, or a narrow enclosed space surrounded with dentinal walls, there can be chances for aggravation of pain, right? So nighttime pain or nocturnal pain or pain associated with change of body position or head position, and most importantly in advanced cases pain is relieved by intake of cold substances, right? So this specific point is given in Cohen as well, right? So this is very very important in advanced cases or in late stages of chronic irreversible pulpitis or asymptomatic irreversible pulpitis. There will be relief in pain, right? So that's important. So these are some of the distinguishing chief characteristic features associated with irreversible pulpitis, right? So when you compare reversible with irreversible pulpitis, obviously in reversible pulpitis pain is mild in nature. Aggravating factors are nothing but it's like whenever there is any stimulus, there will be pain, and on removal of stimulus, the pain sensation is lost and the pain intensity is very less, right? Mild to moderate, and the intensity and the pain is lost once the stimulus has been removed, right? So we usually go for placement of a sedative dressing, or we'll just place it base and go for restoration. So that's reversible pulpitis, also called as hyperemia. In case of irreversible pulpitis, the criteria here is, as I mentioned, pain is very much high in intensity, right? So pain, we have moderate to severe kind of pain, and there won't be any aggravating factors as such, because pain can be sometimes spontaneous, or even if there is an aggravating factor, right, the pain lingers even after removal of stimulus. This is very important. Lingering of pain even after removal of stimulus is a characteristic feature of chronic irreversible pulpitis, right? So along with that, as I mentioned, pain associated with changes in the body posture, and also relief of pain on intake of cold fluids, right? So these are some of the important characteristic features associated with irreversible pulpitis. And remember, in late stages, it's given in Grossman clearly that we assume that percussion is positive only in pathology which is spreading towards the periapical area. But even in late stages of chronic irreversible pulpitis, tenderness to percussion is positive, right? So this is very important, right? So these are some of the important points pertaining to irreversible pulpitis. And also remember, in irreversible pulpitis, as I mentioned, pain is severe. It can be continuous in nature, or it can be even intermittent in nature, right? So these are various characteristics associated with irreversible pulpitis. And again, depending upon the symptoms, we have symptomatic irreversible pulpitis or asymptomatic irreversible pulpitis. All that I have discussed so far now, they are all features of symptomatic irreversible pulpitis, right? So these are some of the important points pertaining to regarding the signs and symptoms associated with pulpitis, right? So coming to the question again, which condition is characterized by pain that is spontaneous and has a period of cessation or intermittent in nature? So it's obviously irreversible pulpitis, because they mentioned that the pain nature or character is spontaneous and has periods of cessation, right? So you can expect a lot many questions from these areas as well, right? One second. Yes, Ajaj, very good evening. Glad you are here, Ajaj. Hope your preparation is going on fine. Yeah. Now let's move on to the next question. So it's in this question, two statements are given, right? So we need to find out, it's not assertion and reason type of question. They have given two statements, and the options are like, first statement is true, second is false. First is false, second is true. Both are true, both are false, right? So these are the options, and now let's go into the statements, right? The statements are, the first one. So we're discussing altogether a different question, right? Internal resorption of a tooth is generally believed to be caused by inflammation due to an infected coronal pulp. I'll repeat. Internal resorption of a tooth is generally believed to be caused by inflammation due to an infected coronal pulp. So that's statement 1. Statement 2. This condition is frequently precipitated by traumatic injury to the tooth. So statement 2 is, this condition of internal resorption is frequently precipitated by traumatic injury to tooth. You see, internal resorption, also called as inflammatory resorption, See, we have different types of resorption, right? Replacement resorption, we have this inflammatory type of resorption, etc. We have this classification, and the clinical features of resorption are very important. They can pose a radiograph and they can ask you a question related to that as well, right? So internal resorption, also called as pink tooth of mammary, right? So as per the first statement, internal resorption as such has no known etiology, unknown etiology, but it is believed that this internal resorption can be because of some kind of infection or irritation from the pulp, right? So usually in cases of inflammatory or internal resorption, we go for pulp extirpation, right? So that with the hope that the resorption process will be halted. So mostly it's unknown etiology, but it's believed that the reason could be an infected coronal pulp. And also, so the first statement is true, right? And coming to the second statement, this condition is frequently precipitated by a traumatic injury to tooth. So usually that's what we observe, right? So in cases where there is history of trauma, right, there can be cases where there is resorption. There can be even associated ankylosis, replacement kind of resorption, external root resorptions, right? So we can have altogether different kinds of resorptions, and resorptions are usually seen in cases where there is history of trauma, right? So that's another true statement, right? So both the statements are true, but here what we need to understand is, when we take a radiograph, internal resorption, we should differentiate whether it's an internal resorption or an external resorption which is being superimposed in the path of taking an IOPA. So to distinguish an internal from external resorption, what we do is we take two radiographs, one radiograph from normal angulation, the other radiograph with a shift technique, right? We have this slope rule, right? Same side lingual and opposite side buccal, Clark's rule or slope rule. So once we follow this shift technique, just remember it's gold standard that internal resorption doesn't shift with shift in angulation, with shift in horizontal angulation, whereas external resorption, as you know, based on the slope rule, there can be a shifting, whether it's placed buccal or depending upon its location, buccally or palatally, right? Internal resorption doesn't shift when you use this technique of slope rule. So that's a standard, gold standard one. You need to keep that in mind, right? So just go through the classification of resorptions, and also mainly focus on the etiological factors and clinical presentation, right? So treatment more or less will be the same, unless and until it's perforating, we go for root canal treatment, right? Perforation, depending upon the level, we go for extraction, right? So that's pertaining to inflammatory resorption or internal resorption, right? Yeah, hope you're able to follow what I'm discussing, right? Yeah. Next, coming to the next question, right? Intentional replantation is often used when root canal therapy fails because it allows canal and or apical preparation and or filling to be done outside the mouth. So we have here an assertion and reason type of question, right? So we have an assertion as well as reason. So here we need to find out whether both statements are true, and also you should try to find out if the reason is justifying or if it is a appropriate reason for the assertion given above, right? So I'll read out the question again. Intentional replantation is often used when root canal therapy fails. So I'll pause it there. Intentional replantation is often used when root canal therapy fails. See, this statement cannot be accepted because for that we need to understand the indications for intentional replantation, also called as a replant surgery. Intentional replantation, also called as replant surgery, it's indicated mainly when a conventional root canal treatment cannot be done or becomes impractical, right? It can be because of the physical or mental status of the patient, or it can be because of anatomical difficulties, or depends on several reasons, right? When a conventional root canal treatment is difficult or nearly impossible to perform, then we go for intentional replantation. It's not when the root canal fails. So that's not the indication, right? So obviously the first statement is false. And coming to other indications of intentional replantation, when there is access to the root canal is blocked, as in case of fractured canal, or as in case of ledge formation, or when the periapical surgery is practically impossible because of anatomical limitations, right? So due to these reasons, when this conventional treatments or retreatments or or apical surgeries are difficult or impossible to perform practically, then we go for this intentional replantation or replant surgery, right? So these are some of the main indications, right? So now coming to the second part of this question. Intentional replantation is often used when root canal therapy fails because it allows canal and or apical preparation filling to be done outside the mouth. So this statement is true because intentional replantation, our goal is to once you remove it, you retrogradely prepare the cavity and then fill it up, and then you can perform these procedures as mentioned, right? So you can allows access to a canal, allows apical preparation and retrograde filling to be done extra orally, right? So this statement is true, but the first statement is completely false, right? So I'll just read out the question once again and then we'll stop it here. So intentional replantation is often used when root canal therapy fails, right? So that's not the indication, because it allows canal and or apical preparation filling to be done outside the mouth. So the first assertion is wrong, whereas reason is correct, right? So try to focus on the indications of intentional replantation, the concept given by Grossman, and also what exactly do we perform, like what procedure is followed while extracting, while going for intentional replantation, and most importantly the consequences of intentional replantation. So usually we have replacement kind of resorption leading to ankylosis, or there can be external root resorption, right? So these are some of the drawbacks or limitations associated with intentional replantation. Just focus on these. So as I mentioned, when you're going through resorptions, right, it's not just the etiology that's important, pathophysiology is not as such very important, but clinical features and the complications associated with these kind of diseases or pathologies is very important, right? So try to focus on these areas while you're preparing for your respective entrance, right? Hope it's clear. So now I'll move on to the next question. So before that, I think we have a comment. Yeah, Aishwarya. Aishwarya, I'll get back to your questions after we complete the set of questions which I have mentioned, which I have in my notes, right? Okay. So coming to the next question, a patient walks into your office holding a cup with a tooth in it. A patient walks into your office holding a cup with a tooth in it. With his tooth in it. What liquid would you least hope the patient kept the tooth in? I'll repeat the question again. A patient walks into your office holding a cup with a tooth in it. What liquid would you least hope the patient kept the tooth in? So it's just asking you the avulsion media in an indirect way, right? So options given are milk, water, saliva and saline. So what liquid would you least hope, or in other words, what is the least indicated transport medium for an avulsed tooth? So that's the question, right? So we have options milk, water, saliva, saline, right? So as you all know, avulsion it comes under LS classification of class 5, right? So class 5 it's avulsion, class 6 it's root fracture. So in case of avulsion, there are few factors which are really very important. So these factors are, the first one is extraoral dry time. So depending upon the extraoral dry time, there can be prognosis. It affects the prognosis directly. If the extraoral dry time is less than 30, usually the prognosis is good. Whereas if extraoral dry time is greater than 2 hours or 1 hour, the prognosis is very poor. There can be ankylosis, or there can be a replacement kind of resorption or external root resorption, right? And the other factor is transport medium. So transport medium, if it's favorable. So in transport medium, we need to look into two other factors. So one is the pH of the transport medium, the other is osmolality, right? So we can have several questions from these discussion topics, right? That's the reason why I'm trying to stress on this. So the factors affecting the prognosis of an avulsed tooth are: number one, it's extraoral dry time. Number 2, it's the avulsion media. Number 3, it's the condition of tooth socket. It should not be fractured, right? And it should be clean without any dirt. It has to be irrigated, right? And also the condition of the root surface, the cementum surface or the root surface, where we should not scrape or we should not clean it or we should not etch the surface, right? We need to have viable periodontal ligament cells for attachment process to occur, right? So these are some of the factors which are really essential in deciding the prognosis of an avulsed tooth, right? So in particular, when discussing about avulsion medium, we need to look into two important aspects. One is the pH of the solution. It should be as close as possible to the physiologic condition, right? And also the osmolality of that solution. And of all the avulsion medium, HBSS, Hank's balanced salt solution, right? Hank's balanced salt solution is considered to be more ideal. And among the given options, milk, water, saliva, and saline, obviously it's milk is considered to be very much compatible because of its high pH close to that of neutral, 6.4 to 6.5, and also the osmolality, right? So milk is the best medium among the given options of milk, water, saliva, and saline. First milk, followed by saliva, because it's a physiologic, natural biologic solution, right? Saliva, followed by saline, and least would be water, right? So water, especially tap water, it's more damaging as per the studies, right? So it should never be stored in tap water. If the patient is conscious and if patient can voluntarily control, it's better to place it. If the medium is available, then better go for HBSS or even milk. If they are not available, then the next best would be patient's buccal vestibule or in the saliva, right? So that would be the best medium. So to the question, a patient walking into your office holding a cup with a tooth in it, what liquid would you least hope the patient kept the tooth in? So it's obviously water, right? So focus on this avulsion. We have believe me, we have lot many questions. Avulsion media, avulsion, what would be the treatment protocol, what would be the splinting duration, and also what would be the complications if depending upon the extraoral dry time. So we have this clinical protocol. If the extraoral dry time is less than 60 minutes, more than 60 minutes, or if it's an open apex case, or if it's a closed apex case, a lot many variations, lot many questions, right? But the concept is simple. No matter what kind of avulsion it is, if it's an open apex, then we try to get the apex closed. We go for flexible splinting, right? So among this avulsion, we have to go for a flexible splinting. Flexible splinting in the sense, we have basically splinting is immobilizing a tooth. Immobilizing any part of a body is called as splinting, right? So splinting, we have rigid, semi-rigid, and flexible splinting. The advantage of flexible splinting is that it allows for physiologic movement of tooth. So this physiologic movement of tooth is very much essential in order to prevent ankylosis or replacement kind of resorption. And remember, our main aim in avulsion is extraoral dry time has to be as low as possible, and the best avulsion media should be available in order to maintain the viability of periodontal ligament cells. Only when the PDL cells are viable, then there can be reattachment and there can be improved prognosis, right? Once replantation is done, in case of an avulsed tooth, then we have to go for a splinting of 7 to 10 days. Ideal case scenario, the ideal case duration for splinting, flexible splinting, is 7 to 10 days or 1 to 2 weeks depending upon the condition. And root canal has to be instituted 10 days after, 1 week to 10 days after replanting the tooth, right? So these are some of the important points pertaining to avulsion. So focus on avulsion. We can have a lot many questions from these areas as well, right? And also you can just look at the video on important topics in endodontics. I would have covered definitely some questions being repeated from this topic as well. And coming to the final question, so I have chosen one question from the instrument so that we can briefly discuss the cross-sectional designs of these instruments as well, the hand instruments, right? The question is, broaches are not used for canal enlargement because they are made of stainless steel. So I have chosen this assertion and reason so that we can have more scope for discussion. So the question is, broaches are not used for canal enlargement because they are made of stainless steel. So if you look at the statements here, assertion and reason, broaches are not used for canal enlargement, which is true, right? because they are not made of stainless steel. Because they are made of stainless steel. See, even that statement is true. Both statements given here are true. Broaches, they are not used for canal enlargement, and they are made of stainless steel. However, the reason is not appropriate. We are not using broaches for canal enlargement not because they are made of stainless steel, but because they are more prone for fracture. So as you know, broaches, we have these plain broaches and barbed broaches, right? Barbed broaches are usually preferred to engage the soft tissue of pulp and extirpate pulp. So broach, the main aim is to extirpate pulp, the barbed broach. So it's mainly manufactured from a round wire, and it has these barbs or projections, and once we have to make sure that they're not engaged into the dentin. Once there is the engagement of these instruments into dentin, there can be fracture potential, right? So we should be extremely careful when using broaches. And also they mentioned that we should not place broach immediately after access opening, right? So we need to enlarge canal a bit, and then 15 or 20 size, and then go for a broach placement, or else there can be engagement of broach into the dentinal walls leading to fracture, right? And of course they are made of stainless steel. See, I've made one video on standardization of endodontic instruments. You can refer that video, where I've extensively discussed about the sizes of instruments, the various standardization principles given by Engel and Levin, and also the importance and significance of night eye and evolution of night eye over stainless steel, right? So nitinol, they have super elasticity and shape memory, so we use the property of super elasticity in case of endodontics, right? So we have lot many important points in that, right? So along with that, also focus on various hand instruments, right? So files and reamers, what is the basic cross section, and as per standardization, which cross sectional blanks are being used for which kind of files, right? So usually files, they are made of a square blank. Just remember it this way. How do you remember a file, square, and reamer, triangular blanks? It's simple. File, you know, this customized file where you keep A4 sheets, right? It's in square shape, right? More or less square shape, right? So just remember that way. So files, they're made of a square shape, whereas reamers, which have greater cutting efficiency, right? So they are made of a triangular blank, right? Moreover, as per the standardization, as per the latest record, all finer size instruments, small size instruments are being manufactured by square blanks, whereas large size instruments are being manufactured by triangular blank, because the concept is simple. Triangular blank, the cutting efficiency is more, however they are more prone for fractures, right? That's the reason why they are not being used for finer size instruments. Whereas square blanks, even though the cutting efficiency is comparatively less, they are more resistant to fracture, right? So that's the reason why we are using square blanks for finer instruments, right? So we have n number of points, n number of important points in these particular topics, right? So you can refer a standardization instrument. Also, I posted a few videos, around 8 to 10 videos in endodontics. You can refer them, and we'll be doing more and more videos, and simultaneously we'll be posting them in YouTube, a few in YouTube, and also in our e-classes site, right? So this is what I wanted to discuss in this live session. So we discussed a couple of questions, right? So I'll just go through the comments, and then we'll see whether we can have a kind of discussion pertaining to these questions, right? Okay. Hi Aishwarya. Okay, we have a question from Aishwarya Ajaj as well, right? So Aishwarya says, sir, you mentioned that in late stages of irreversible pulpitis, TOP may be observed. Aishwarya, it's not maybe observed. TOP is present in final stages or in advanced stages of irreversible pulpitis, right? Okay, let me just go through the question. Yeah. Okay. Yes. How will we differentiate it with apical periodontitis? Yeah, that's a good question. See, as Grossman didn't mention, that's true. Grossman, I don't think then it's Grossman. I think it's in some periodontic textbook, and also in Engel or Cohen, but I'm not sure of the book. But it's mentioned clearly that in late stages of irreversible pulpitis, there is tenderness to vertical percussion. So a very good question from you. So how do you differentiate? So obviously, take a radiograph. Radiographically, you find almost no changes in case of pulpitis, right? So because the infection is confined to the pulp, and also in case of apical periodontitis, you can see a break in continuity of lamina dura, etc. So that's pertaining to a radiographic observation. But before that, you have these symptoms, right? You have these signs and symptoms. So based on that, you can go ahead and differentiate this irreversible pulpitis from apical periodontitis. So as I mentioned, all the signs and symptoms, you can apply them to irreversible pulpitis, right? Apical periodontitis, yes, there will be tenderness to vertical percussion in both, and that you can differentiate radiographically as well, right? And also this palpation, right? So you have these important signs and symptoms which helps you in differentiating, right? Hope it's clear. Yes, Aishwarya. TOP is seen in all late stages of irreversible pulpitis as per the literature. And also based on the clinical experience, I can tell you that it's not occasionally, but in most of the cases, almost all the cases of irreversible pulpitis, right? So when patient complains of pain, usually a patient often comes to clinic with severe pain, right? In those cases, when you percuss the tooth, right? So obviously there will be pain or tenderness to vertical percussion, right? Just refer Cohen. It's given clearly. I've gone through it, and you can refer that, right? Yeah, even while we were in undergraduation, our periodontic teacher has given us this explanation, and at that time itself we referred, and even lately I referred, and yes, that's true. That's authentic information, Ashwarya. Yeah, you're welcome. Ajaj. Yes, Ajaj. So the answer is water. When we assume that the patient has scientific know-how, otherwise water could be the most common as a layman's point of view. Yes, that's true. That's true. Yes, Ajaj. Should have scientific know-how. So that's the problem we have, especially in case of avulsion. Even though we have a lot many in lab, we have various studies going on. We have this HBSS, Vitaspan. I don't exactly remember then. So we have a lot many avulsion media, but the problem is availability. So we can have questions in these aspects, right? The ideal avulsion medium. So we can have question on the ideal avulsion medium, and also we can have a question on the best avulsion medium based on availability. Obviously that would be milk or coconut water, right? So depends upon the question, right? So the best would be obviously based on the lab studies, based on the in vitro studies, based on the publications, and also we should look into the best medium based on availability, right? So we can have questions accordingly as well. Swapnil. Hi, Swapnil. Yeah. So what's your question? So please differentiate between pulp necrosis and irreversible pulpitis. Swapnil, pulp necrosis, usually it remains asymptomatic, right? Irreversible pulpitis, hope you have gone through the earlier part of this video. See, when you go, I'll just go straight and answer in brief to this question. So based on symptoms, you can differentiate, right? So pulp necrosis, when you go for a vitality testing, that's because we're talking more of sign. See, always remember, sign is considered to be a more valid and reliable than symptom, because patient can say anything, right? But it's we who needs to test the tooth and then objectively analyze it and then give the diagnosis, right? So signs are often considered to be more accurate and reliable. So we'll discuss the signs, right? So pulp necrosis, when you go for thermal testing, there won't be any response. HPT, no response. Thermal test, heat test, cold test, no response, right? So that would be the scenario in case of vitality testing. Irreversible pulpitis, there can be delayed response, or there can be a lingering type of pain on removal stimulus, right? So based on that, you can differentiate whether it's a case of pulp necrosis and or irreversible pulpitis, right? And remember the symptoms. See, always remember the symptoms given by patient itself gives us a clue to diagnose the condition. William Osler, he's considered to be a great physician. You just Google the name William Osler. You have lot many quotes. I'm his fan, in fact. So one of the quotes given by Sir William Osler is, the diagnosis is given by the patient himself. It's not that we are diagnosing, because the chief complaint given by the patient itself drives us into conclusion, into a provisional diagnosis, a provisional conclusion, right? So chief complaint, history are the key in diagnosing, right? So that's very, very important. So based on the history, based on the chief complaint, we can come to a provisional diagnosis, right? Okay, Swapnil, hope I answered your query. Right. So we have any more questions? It's already past 40 minutes. So have any questions? You can discuss, right? So I'll also simultaneously look into a few more multiple choice questions and then try to discuss them. So we have a lot many case based questions. You're welcome, Swapnil. Yeah. So you can have a lot many case based questions, and also I'm planning to make one video on image based questions. Especially, we'll be doing a lot many questions covering various subjects, but in specific this week we'll focus on endodontics, where I will try to make one video on image based questions or picture based questions, because we have usually this, they'll post your radiograph, they'll give you some related information pertaining to that radiograph, and then they can ask you a question related to that, right? So case based questions, we'll have a discussion, we'll have a separate video pertaining to that, right? Okay. So actually, I'll just discuss one question, because this question was posed to us when we were in final year, and it's quite interesting also, right? Just give me a second. Yeah, guys, hope you're following this session well. Any feedback, any constructive, positive, of course, even negative feedback is welcome, but if any positive, constructive feedback to improve, then we'll definitely consider, right? So, have any feedback, then you can just post it in the comment. Right, let's discuss one question here. Yeah, Aishwarya, image based questions on radiology. Already, radiology, we have questions in e-classes, Aishwarya. You can refer that when you enroll to our course, Aishwarya, fine. So I will also post them in YouTube as well, right? I will definitely do more videos, image based videos exclusively, because we'll be completing our regular schedule next month or August ending, I guess. So once we complete our regular schedule, then I'll have more, I can spend more time on these MCQ discussions and also these image based questions. I'll definitely focus on image based questions as well, right? So the question which I wanted to discuss now is the most important criteria in using irrigating solution is, we have options: volume of irrigant, thickness of syringe used, concentration of irrigant, and none of the above. So here the most important criteria in using irrigating solution, just remember, when going for irrigation purpose, the needle gauge that has to be used, or the size of the needle that has to be used, is 27, right? So 27 gauge needle is used, and the most important criteria here is the volume of the irrigant, right? So that's why if you observe the protocol for irrigation protocol, they'll specifically mention how much volume of irrigant has to be dispensed into the canal for a specific duration of time, right? So the most important criteria in using irrigating solution is volume of irrigant, thickness of syringe used, concentration of irrigant, none of the above. So it has nothing to do with the concentration of irrigant or thickness of syringe, because as studies show, hypochlorite or any other irrigating solutions, right, even if you vary concentration, it doesn't have much impact, because see, the focus here is to reach the apical third of the canal, right? So the gauge of the needle, and also most importantly the volume of irrigant plays a crucial role, right? So previously the concept used to be like cleaning and shaping, right? So we clean the canal, we shape the canal, we call it cleaning and shaping. But now the focus is on shaping followed by cleaning. We're trying to shape the canal using various latest anti-rotary instruments, right? We're trying to shape the canal in order to gain access to the critical apical third of the canal, right? So we're shaping the canal for sake of cleaning it, for sake of gaining access to that critical apical third area. And for that we have this endovac, we have this apical negative pressure system, we have this finer photon induced photoacoustic streaming, we have latest machinery being employed in order to effectively reach or send solution to the apical third area. So the paradigm is shifting gradually, as like the extension for prevention or prevention of extension. We similarly have a lot many changes happening, and in future definitely there is going to be a day where there will be more focus on regeneration. Regenerative endodontics already studies are being done extensively for the past decade, right? So we can expect more and more developments in near future, and maybe in future when you go with pain or necrosis, as you people are asking, maybe there will be a day where they'll just go for regeneration. And for regeneration, the key factors include stem cells, scaffolds, and growth factors, right? PRF or PRP, right? I will not discuss, we'll not go into details of regeneration now. So actually I've previously taken on theory class, so it's still fresh in my memory, right? So any other questions you have, I'll be happy to hear, right? Just looking if at all I can discuss a few more questions. Post configuration, I think I'll just look into that question also, and then we'll discuss. Because post and core, we can expect lot many questions. The surface features of posts, and also what should be the configuration of post, etc., right? I'll just go through that question. Any questions on post? Yeah. So we have one question. I'll just select one question from the post and core as well. Which are the following post designs offer greatest retention? Even this question was asked in AP 2013 when we were writing entrance. So which are the post designs offer greatest retention, right? So options include a smooth parallel post, smooth tapered post, serrated parallel post, and cast post. See, when you compare a cast post with a fiber post, right? So obviously a cast post or a custom made post has this advantage of conforming to the root canal, internal root canal anatomy, right? So since the question is on greatest retention being provided by which orientation of post, see, when you have this, we have these various designs, right? Parallel sided post, tapered post, smooth post, serrated post, right? So just remember, it's very simple to understand also. When you have this tapered post, assume this as a canal. Let me just draw on a paper, right? See, I hope you can see. Yeah. I think there is a lot of glare. I think you can see now, right? Yeah, fine. So assume this as apical third of the root, right? So this is the surface morphology of the root, and the inner one, the conical one which I drew, it's not ice cream cone, by the way, it's a tapered post, right? So assume this as a tapered post. When you have this tapering, there can be wedging forces acting. And as a result of those wedging forces, there can be increased chance for fracture, right? So what we prefer usually is, rather than tapered post, we go for parallel sided post. And moreover, with parallel sided post, we have this added advantage of frictional retention, right? And to be more specific, a parallel sided post with a tapered apex is usually preferred, because that conforms to that follows the root canal anatomy, right? And coming to the surface modifications, we have this smooth and the serrated. Obviously serrated posts, they'll have the advantage of added retention, right? So among the given options, option C, serrated parallel post would be the appropriate option, and that would add to greatest retention among the given options, right? So that's pertaining to post. And see, refer prosthodontic considerations given in Grossman. You have various concepts pertaining to the width of post, right? Proportionalist, you have this proportional. We have three theories related to the width of the post, and also we have numerous other important features pertaining to the surface characteristics and also the surface configurations, as we have discussed now, right? So conservationist, preservationist, and proportionist theories, right? So you just go through those theories as well, right? So these are some of the important areas which you can focus on, right? So we still have 10 more minutes. I'll just see whether we can discuss few more multiple choice questions. And regarding, I'm sorry, I just forgot to mention regarding the anatomy of pulp cavity. See, we're having many questions from on the percentage incidence of extra canals, right? So you need to take the pain and memorize the percentage incidence of various extra canals. We already made one video. We'll be posting them in our e-classes today. So we have extensively given in case of anteriors, in case of premolars and molars, the percentage incidence of extra canals, and also the cross-sectional shape or access cavity shape of various teeth, right? So we can expect many questions from these, and we already have many questions being repeated from these areas, right? So you can refer to my video. I've extensively discussed along with the percentage values in table format, and we'll post that in e-classes today by tonight, right? So within 2 hours we'll be posting it, right? So they are in editing phase now. So try to focus on that, right? You can refer Grossman, you can refer Engel. Engel, we have these tables pertaining to a percentage incidence of canals, right? So we have one question related. The reason why I got that is because I've seen one question related to that. The question is, in upper molars, this canal may divide to form fourth root. So which canal divides to form fourth root? Fourth root. Okay, the options given are palatal, distobuccal, mesobuccal, and all of the above. So I reckon it's mesobuccal, because MB2, the chances of finding MB2 as per the studies, it's around 52 to 55%. Ever imagine? It means when you're doing access cavities, in case of upper molars, so there is always a 50-50 chance of finding a fourth canal, which we commonly neglect, because the moment we find one MB canal, we feel like we have done our job and we'll totally leave it. But the chances of finding an extra canal in mesobuccal root is 52%, right? So we should be extremely careful in finding out this extra canal, right? Once a canal is missed, no matter how well you obturate the remaining canals, there can always be a recurrence of symptoms a few years later, right? Just keep that in mind, right? So the question is, in upper molars, this canal may divide to form fourth root, and the options are palatal, distobuccal, mesobuccal, all of the above. So it's obviously mesobuccal. And the location of mesobuccal, right? So mesobuccal MB2, mesobuccal, the first canal is found directly beneath the mesobuccal cusp tip, whereas MB2 is found in different locations, and there are 6 possible locations for this MB2 canal, and these 6 possible locations are given by Nalapati, and this is discussed well in Grossman, right? Also we'll make a video on this as well, right? So these are some of the important points pertaining to MB2, right? And also when you're referring this post and core, you can go through along with the topics which I mentioned, you can even go through the ferrule effect as well, right? So we have many concepts, many topics, and so we still have a lot to learn and a lot to discuss, right? So it's a never-ending process. Learning is a never-ending process. So often we assume that, so once we complete graduation, or once we go for PG preparation, or once we complete our PG, we learn everything. But unfortunately, science is so rapidly changing and advancements are coming so rapidly that we need to update ourselves on a regular basis, right? It's not just a standard textbooks. If you are an enthusiast and if you are really willing to learn a lot, then obviously you need to refer various journals and articles as well. So it's a never-ending process, learning. And the moment I go through standard textbooks now and I refer, I feel like I'm still learning a lot. There are many points which I didn't knew, and I'm still in a learning phase. Every one of us, I feel, will be a continuous, will be a student lifelong, right? It's only the experience. With experience, you'll be accumulating as much information as possible, right? And with discussions, the best thing about these live sessions and group discussions is that you'll have scope to understand more and to increase your understanding on a particular topic, and also you can know where to focus and how other people are thinking, right? So always learning is a continuous process, and we never can't say that yes, this is the end point and I've learned everything, right? So you should be humble enough to accept that, and that really keeps you moving, helps you learn more and more, right? Just keep that in mind. So it's 54 minutes. I'll just stay for a few more minutes, maybe another 5 to 6 minutes, and you have any questions, Any feedback, anything, you can comment or you can mail us at proudtobedentist@gmail.com. Right, I'm just commenting that here. You can drop a mail there, right? So how is it going? How is your preparation going? So make sure that you don't get demotivated at any point of time. We still have 4 to 5 months time, and I personally feel this is perfect, right? You spend maximum amount of time a day. Just stay motivated, just stay focused, don't give up, just hang on, don't give up, stay focused. If at all you feel demotivated, then intrinsic motivation is the key, or if you need any kind of extrinsic motivation, I'm there, right? So you can mail me. I'll be suggesting you, I'll be giving you a few tips, and I'm sure it would be of some use for you, right? So but try to focus on incorporating or inculcating this intrinsic motivation, which is even more powerful and effective. Just assume that you'll be getting the first rank in this year's NEET, and proceed that way. Give your best, don't worry about the competition. It's all relative, comparative analysis, right? You give your best and you will be the best, right? Just keep that in mind. Don't worry about what other guy is doing, right? So just give you 100%, and ultimately you should be happy. You should have the right attitude. You should be happy. If you're unhappy, if you're tensed, if you're anxious, then obviously you are at a disadvantage, right? So the other people in the competition will definitely have an edge, right? So you should be happy first. You should be happy because, see, have you ever realized the fact that in graduation, in the first 4 years, we never learned so much. I mean, when compared to the PG preparation, if you are seriously preparing for PG entrance, there is a lot and lot to learn, and you feel like you should even learn more. That's the reason why I say that when you start your preparation, start with 1 hour, just 1 hour a day, only 1 hour a day. The moment you go on and on, you continue preparation for weeks together, then you will understand and realize the fact that 1 hour is not just sufficient. 2 hours is not just sufficient, or maybe 3 hours, 4 hours, 5 hours, 6 hours. This is not at all sufficient, because subject is so vast. We have a lot to learn that we feel like even 24 hours a day is not sufficient, right? So that's how the reality is. So for that, it doesn't mean that we should get depressed thinking of the reality. It means we should give our 100%. It means we should work extra smart, hard, as well as smart work, right? That's the reason why we keep on saying it's not just the number of hours you put in, it's the amount, it's the way, it's your approach, it's your planning, it's your schedule, and it's your attitude, right? So that's even more important. So just don't get demotivated thinking that, as I mentioned, 24 hours is even not sufficient. No, it's not for you to take it negatively. Take it positively. We have two sides of a coin when we talk about something, either positive or negative, right? So choose the good one, good side. Be positive and optimistic. That keeps you moving. It's not that it will give you everything, right? So if you're negative, if you're pessimistic, obviously you're going to gain nothing good. In fact, that's going to hamper your preparation. But being positive, being optimistic is the best option you can choose now, right? So that keeps you moving. So try to focus on that particular aspect. Be positive, be confident, and give your best, and leave out the rest. Don't worry about result. Give your best, leave out the rest. Obviously, when you give your best, the best comes to you, right? Just keep that in mind. I'll conclude with this. So hope this session is of some use for you, right? Hope you learned something, and definitely I've learned from your questions as well, right? Hari Krishna. Hi Hari Krishna, a very good evening. Glad that you joined us live. Right, so it's 58 minutes, right? You have any final comments or questions, you can just comment, you can just post them. I'll be happy to take them up, right? Suyog. Hi Suyog. Keep up with good work, sir. Thank you, it's my pleasure, and thanks for reciprocating as well, right? Suyog, all the best to you too. Right? Yeah. So any questions? Okay. Yeah, you're welcome, Sayok. You're welcome. So next live session, we'll do it this Saturday. We'll do this Saturday the next live session, and we'll choose one general topic, right? Yeah. Thanks, Doctor, by Riza. You're welcome, Riza. Glad to hear from you. Endless Rain. Endless Rain, I asked you, what's your name? Is it Endless Rain? Okay, sir, how to read DM? Dental materials. Yeah, Endless Rain, you can just mail me at proudtobedentist@gmail.com. I'll just sum up that in brief. Go through synopsis. So topic wise, practice as many multiple choice questions as possible. Make a habit of having stick notes or customized notes by referring standard textbooks like Phillips or Craig. Go for Phillips, that's the best one. And then repeat the cycle, right? So DM, it's a very elaborate, exhausting and memory based. You need to have a customized notes with key points is very important. Previously, one student, when I asked her to show her notes, she was writing almost everything, right? Writing everything doesn't take you a longer distance. You'll stop somewhere in the middle, because writing everything given in textbook or given in that topic drains you, and it's unnecessary. You understand that? You should understand that. Only key points, only those topics or those points which you feel you're not able to memorize them, or which you feel they're important, only those points or those that information in form of key points is essential, right? So just don't keep on writing everything, right? That, and ultimately what happens is, by the end, the notes becomes inaccessible, in the sense you don't feel like going back and study everything. So it should be in key points, it should be short and cute, so that you'll have the drive to refer again and again, right? Endless Rain, you can mail me if you want more elaborate discussion on this, right? Swapnil, yeah, Swapnil, so please share important topics on other subjects. Yes, Swapnil, we have been doing this for the past few weeks. Yes, definitely. In the coming weeks, we'll be uploading the list of important topics and other subjects also. We'll complete that in 1 month or 2 months. It takes some time, because we need to carefully look into various topics, right? Already we have the list of important topics for maybe 4 or 5 subjects. I'm not exactly sure. You can refer our channel video. I mean the videos. You'll find the list of important topics in various subjects, right? 4 or 5. We'll do the rest as soon as possible, Swapnil. Right? Thanks for your interest. Right. So guys, glad to have you live. So as I keep on saying, that really motivates me. This is my motivating factor, and I should thank you for your support as well, right? So thanks for your trust in me, and thanks for your support, and thanks for your love, right? So just keep smiling, that's more important, and smile makes you look even more beautiful, right? So right, all the best. Yeah, you're welcome, Swapnil. So all the very best. Be positive, stay focused. Sir wants to elaborate video on oral pathology. Hare Krishna, yes, definitely. You mean to say the list of important topics, Hare Krishna, or you're talking about the topics, subject topics? I didn't get you. Sir wants to elaborate video on oral path, so as to we have a clear view. So if it's regarding how to prepare and all, definitely I'll definitely make a video on oral path, because that we feel very it's a bit complicated, right, to go through Schaefer's, read that plenty of information given there. We'll definitely plan a strategy, and I'll share with you. Yeah, yes, done Hare Krishna. We'll do it as soon as possible. Right now we're having a schedule going on, so we are immersed in it right now. So definitely in the coming weeks we'll definitely have a video on strategies to be implemented on how to master, how to approach oral path, right? Definitely. Swapnil, I'm a fan of yours. Strange, I'm not a celebrity, but anyways, I'm humbled by that statement. Thank you so much for your love, Swapnil, and love you too, right? Yeah. So guys, we'll just wind up the session. Glad to have you all live. So all the very best. Keep smiling, as I keep on saying, keep smiling, and there is nothing to worry. Always having that right positive attitude will drive you forward. Just keep that in mind. Be positive and optimistic, and give your 100%. You're all young, right? You're all very young, energetic, and dynamic. So you should be like this. You should give your 100%, right? Leave out the rest, give your best, and the best comes to you, right? All the very best. Keep smiling. Good night, take care. Meet you next Saturday with a general topic which I'll announce on social media once again, right? Yeah, bye. Good night.